the monkeypox case, as well as around the wearing of masks in South Africa. So we've put together a panel that will be answering some of the questions. We have Dr. Jacqueline Beyer, as well as Professor Adrian Purin, as well as Professor Cheryl Cohen. And we will be starting with Professor Cheryl Cohen in terms of the repealing of masks. What now? What does it mean for South Africa? So I'd like to invite colleagues already to put up their questions on the chat so that we can get the discussion going. Just to introduce myself, my name is Sinitlandla Jimo, and I am the Senior Communications Manager for the NICD. So before we start, there has been some concerns from certain parts of society in terms of the statement that was released by Professor Adrian Purin. So I'm going to invite Professor Adrian Purin just to welcome all the colleagues and also touch on some of the concerns that have come up already with regards to the announcement of the first case of monkeypox in South Africa. Professor Adrian Purin, over to you.
Thank you very much, Sinitlandla, and thank you to all the colleagues who have joined us at this particular press briefing. As you know, when we investigate an outbreak, there are always characteristics that are specific to that particular outbreak. And if this is one of those particular characteristics, we need to acknowledge it and work on it. However, as NICD, we strongly condemn any discrimination against anyone, because in this particular outbreak, we do know that the levels of susceptibility vary, and that's by particular conditions, and we need to acknowledge that in order for us to prevent further transmission. But anybody can be susceptible to this particular infection. The risks may vary, but anyone can be. And therefore, we do strongly condemn taking out of context any statements that come out of this particular outbreak against any particular group, whether that be sexual orientation or race or religion. We strongly condemn that. So I look forward to the discussions that we will take place, and we will certainly be monitoring our social media and remove any statements that are against our current policy with regard to any form of discrimination. So thank you very much. Thanks to the
Okay, thank you so much, Prof. Again, I would like to welcome colleagues that are just joining us now. If you have any questions, we won't be doing any presentations because we assume that all of you have seen the statement from the minister as well as from the NICD concerning monkeypox, as well as the repealing of masks. So we'll just allow you to answer the questions. The purpose of this session is to really engage and to answer all your questions, because we might not be able to honor every invite for every radio show and every television show and every news bulletin. So we have created this platform to answer all the questions that you may have and to really establish understanding with you. So if you have questions already, you may just put them up on the group and we will relay them to the relevant experts. So in terms of repealing of masks in South Africa, I'm sure all of you would like to know what now, how do you protect yourselves from COVID-19? So I'm going to invite over Prof. Cheryl Cohen to answer some of your questions. So yeah, please do take up the opportunity to put up your questions already. Prof. Cohen, over to you.
So thanks, Sinitlandla, and thanks everyone who's attending this Q&A session today. You know, I think just as background to the repealing of the regulations, and as Sinitlandla mentioned, I'm not going to give any presentation. I think the purpose is really to take your questions, but I think it's important to note the epidemiologic background in which this declaration or this repealing has occurred, where we've just really come out of the resurgence in COVID that we saw with the BA.4 and BA.5 subvariants. And I think what's really important and very positive to note is that with the emergence of this variant, and this variant did have some immune escape characteristics, which meant that there was quite a lot of spread in our populations, and it did manage to transmit even though we have high levels of immunity. While we did see the case numbers go up, what was really notable is that this decoupling of case numbers from hospitalizations and deaths, which was the phenomenon that we already saw starting with the Omicron wave was even more pronounced in this resurgence. So the cases went up quite substantially, although we think not nearly as much as they would have if there'd been more demand for testing. I think a lot of people didn't test, whereas they might have tested before. But even so, while we did see an increase in hospitalizations and we did see an increase in mortality, the levels to which these increased were much, much lower than we'd seen in previous waves. And this is a very reassuring epidemiologic picture. And we think that by far the most likely reason for this epidemiologic picture is, of course, because of the very high levels of population immunity that we have in South Africa now. So the South African National Blood Service released a paper a few weeks ago where they estimate that 98% of South Africans have antibodies against SARS-CoV-2. Many of these will be from natural infection. The majority would be from having had the infection at least once. Many of these are also from people having received the COVID vaccine, and many, may have a combination of both of these. And what these very high levels of immunity do is that while they may not prevent a spread of the virus in our communities, they do have a very, very measurable and marked effect in terms of attenuating severity and reducing the risk of hospitalization and mortality. And in the light of that, it is appropriate that the regulations be repealed now, because essentially these control measures and these regulations need to be proportionate to the risk of the disease. And we see that the risk has come down, and therefore it is appropriate to then relax our controls. Now, what's really important is that obviously we still need to be monitoring disease, and we know that
apologies for that, colleagues. I think we lost Professor Cheryl Cohen, and I think it may be as a result of load shedding where she is. So what we'll do is we'll wait for her to come in, but we'll take some questions that have come in terms of Monkeypox, quite a few that we can deal with. So can I ask Dr. Jacqueline Vea to just come up and open your camera and unmute, and I'll read through some of the questions that we have received so far.
Hi, Sine, I'm back. I don't know is everybody still there?
Yes, we are all here. Yeah, sorry for that inconvenience. We lost you a bit there, but you can carry on. I do have some questions that have come in.
Great. So sorry, we're being load shedded. So I don't know if the generator was on, but anyway. So I'm not sure where I was up to, but I think the important point is that at this time where the epidemiologic situation has improved so much, it is appropriate that we repeal the remaining regulations. But what NICD will really continue to monitor COVID with all the systems that we have been using up until now. And so should there be any resurgence or concern, we'll know about that quickly. And if needed, things could be upscaled as appropriate. So I don't know, do you want to go into questions, Sine, rather than me carrying on?
Please. Yeah, thanks, Cheryl. But that was very insightful, I must say. I do have a question from Cape Talk, and they wanted to find out, if you test positive for COVID-19, should you still isolate for a week? And what about children who test positive? Are they to stay at home and away from school? And what is the period for that?
So currently, and obviously this is all very new to all of us, I'm not aware on any of those that guidance changing. I think what we at NICD are recommending is that this is all part of COVID moving to be more like other respiratory diseases. And so if you have flu or you have any respiratory disease, right, you should be staying home. And for most of those diseases, we recommend stay at home until the symptoms have resolved. Obviously, because COVID is more formidable, we have slightly more formal regulations where we specify a number of days, which is 7 days. Now I think going forward, from the lifting of the regulations, there'll be a process of looking critically at all of those other different aspects. For example, the 7 days isolation. At this time, I would say, it's not appropriate to change that guidance, but I think we that in the very short period will be looked and decided whether those types of guidance should be repealed. But obviously, if you're sick, it's best to stay at home.
Okay, thank you so much, Cheryl, for that question. Obviously, COVID-19 is still a reality in South Africa. Can you just explain what, I know you've touched on it, exactly what phase are we in terms of COVID-19? Can you say that we are now endemic?
So thanks for that. I think endemic is people, for COVID, there are a lot of definitions and people define phases, but endemic is usually a term that's used to say a disease that circulates all the time in a country, whereas epidemic is more cases than expected in a certain place in a period of time. Now, I think what we're observing is the transition from epidemic to endemic, but we don't really know what so-called endemic COVID is going to look like. For example, will we have one season a year like we do for flu and RSV, or will it maybe be twice a year like we've been seeing up until now? Will the season be in winter, or will it be in autumn like we see for respiratory syncytial virus? So we're not, I wouldn't say we're in the endemic phase, but we're in that transition period where we are observing the disease to be transitioning from epidemic to endemic, and what drives this endemic is the high levels of immunity. So perhaps we're not quite there, but we are really in that transition phase, and I suppose in that regard the whole world is sort of finding their way in terms of changing guidance as the epidemiologic situation evolves.
I think that's it for questions.
Can I make one point, Sine, because I didn't get to finish answering your question about what do people do now that masks are repealed? And I think the most important thing that people can do is make sure they have their COVID vaccines. I think there's a very common misconception out there that if you've had COVID, that means that you're protected against severe disease. And that really isn't the case. There's a vast body of very well-conducted scientific research, including a substantial body of work from South Africa, that shows that even if you've had natural infection, there's a substantial benefit conferred by vaccination in terms of protection against severe disease. So people shouldn't assume because they've had COVID that they're protected. Really, the important thing is to get your vaccine to make sure that you're protected against getting into hospital or dying. And along with that, what's really important is to have those booster doses. So what we know is with the new variants, the protection from infection and from vaccination wanes with time. And again, a very, very strong and compelling body of evidence that shows that the booster dose really improves that protection and gets your protection up to the levels that we want to make sure that you can keep out of hospital. I think, just because the regulations are being repealed doesn't mean that COVID has gone away. And it also doesn't mean it stopped being a very severe disease that we need to protect ourselves against. So really the bedrock is vaccination. And then, as I alluded to, all those other practical measures that we've done all along for other respiratory diseases, hand washing, stay home when you're sick, cough hygiene, etc. And then just to remember, just because masks are no longer regulated, it doesn't mean you can't wear a mask. Wearing a mask, a well-fitting mask, you certainly are free to do it, and it can confer additional protection as well. So I think what this is moving is the control sort of from an external control that says you must wear a mask to allowing people to more take their own decisions to reduce their risk, as we do for many other respiratory diseases. Thanks.
Thank you so much, Cheryl. I know you have another appointment, but I do have two last questions for you. They are from Arisa Janse van Rensburg from Health 24. So what does the a future look like in South Africa in terms of the virus? Will we still see waves, or will the virus become seasonal? And I think you kind of touched on it. And another question that she has is that there is now a large rise of cases in Europe, where they have also abolished all regulations. Can we expect to see the same sort of rise in South Africa at some point? Over.
So those are great questions. I think in relation to the first question, I think we don't really know. As I said, I think we are observing the transition to endemicity, and I think that's one of the purposes of our programs, to really monitor and describe what happens with COVID. We would expect that, and we have seen, right, COVID over time has been behaving more and more like other respiratory diseases. So we would expect that to continue, and that eventually it will settle into a pattern like other respiratory pathogens, where we have some kind of regular seasonality. We know that it might circulate at low levels at all times, and then it would come up at certain times of the year, perhaps the winter, perhaps not. So I think we are definitely observing that transition. We know it's COVID, and so anything can happen, and so we can't exclude that a new variant might emerge, and that might cause us to have to implement more control measures. In Europe, we're seeing an increase, and that increase is mostly related to some of the subvariants of Omicron. So a lot of it is the BA.5 subvariant, which is this resurgence that we've just seen in South Africa. And certainly our resurgence, while we did see an increase, there was some concern. We really saw that decoupling. I think it's important to note in South Africa, there's a lot more immunity from natural infection compared to in Europe, and that might offer us some benefit just in terms of having a more broader and more durable protection on a population level. So I don't think in Europe you can say it's related to the lifting of restrictions. Certainly we know masks do offer a benefit. They do decrease transmission, as does restriction of gatherings. And so there may be some increase in case numbers, and we will be monitoring that. But I feel that currently the epidemiologic situation certainly does not mean that we need to have a major concern about a large resurgence at this time. But obviously that is the purpose of our surveillance, to monitor it, and also very important to have those early warning surveillance like wastewater and other programs that'll tell us early on if there is any problem, and the genomic surveillance to look for variants and pick it up early.
All right, thank you so much, Prof. Cohen. So we'll end it there with you. If there are any other questions for Prof. Cohen, you're more than welcome to still put them up on the chat, or send them to myself on sinitlantle@nicd.ac.za. We'll make sure that you get a response from one of our experts. So we are going to move on to issues around monkeypox. I've got quite a few questions to get through, so we'll just get started with that. Dr. Jacqueline Vea, if you can let our media stakeholders see your face while we take these questions. I have a question already from Mia Milan from Betty Sisa. So her question is, how well does the smallpox vaccine protect monkeypox, and who in SA received it? Until which year was it given? I'm not seeing Dr. Vea. I don't know if it's just on my side, but hopefully she's still there. Dr. Vea, over to you. Okay, I think we may have lost her. We'll give her a moment to join us again. But some of the questions for now, Professor Adrian Purin is with us, and I'll direct some of those questions to Professor Adrian Purin. I think also Nivashan Govender is here to assist us with some of the questions. So another question is from Storm from the South African. When did the NICD first become aware of the infected patient? And I think for this one, I'll just draw on to Nivashan Govender to assist us with the questions, and then Professor Adrian Purin can jump on as well while we wait for Dr. Jacqueline Vea. Over.
Apologies, Sene, your sound broke up. Could you repeat the question?
Certainly, I can. So when did the NICD first become aware of the infected patient? This question is from Storm from the South African. Over.
Thanks, Sene. So the patient, we received a query through the NICD doctor on call hotline, and the case was discussed with doctor on call, and through working through the case details, the decision was made to test for monkeypox. So this happened on late Monday, and so by the time the sample got to us and did the confirmation, and then obviously the news as released, as everybody is now aware. So it was Monday.
Thank you for that, Nivashan Govender. Nivashan Govender is our emergency operations manager. So he's been working closely with many emergencies that we've had to deal with here in South Africa, including listeriosis, COVID-19, and others. I'm going to allow Professor Adrian Purin as well to make a comment based on that question. Over.
Yes, thank you. I'd like to just comment on Mia Milan's question. So I'm not sure the exact date when South Africa has stopped the vaccination of smallpox, but I think individuals younger than the ages of 40 to 50 are thought to be not immune to smallpox. And the effectiveness of the vaccine against monkeypox is thought to be about 85%. So I guess the concern has been that the fact that, in fact, because we've not been continuing to vaccinate against smallpox, of course, that there now is an immune gap that has resulted, that may in part explain what we are currently seeing, at least in some of the endemic countries as well. Thank you.
Thank you so much, Prof. Purin. I'm going to move on to another set of questions. If you had chickenpox, don't you have immunity against the monkeypox? On the CDC website, it says that monkeypox can be spread through respiratory secretions during prolonged face-to-face contact. Can't masks help prevent the spread of this case? Question number 3, how contagious is this compared to HIV? It's fairly easy to avoid HIV, even being around HIV positive individuals all day. Are any extra precautions needed for monkeypox? How is the sexual preferences of the persons affected at all relevant? I think this is a very important issue that we have covered and Prof. Purin covered earlier on. We've seen some individuals use some of the information provided out of context to spread hate and bigotry, and we really distance ourselves from that. The information provided by the NICD is purely for public health purposes, and it's not to discriminate against any group. I'm going to allow Prof. Purin to answer these 4 questions. Prof, let me know if you'd like me to run them over.
Yeah, I'll try and cover. I think I've got them, but if I've missed anything, please assist me as Sidney Lumpler. So the first question is about, if you like, transmissibility. So compared to other viruses, and in particular, and if you think about smallpox specifically, I know that Jacqueline doesn't always like us referring to smallpox, but it's less transmissible. So you really need really close contact between individuals, close and prolonged contact. So that means, for example, face-to-face contact, where, for example, droplets could be one form of transmission, as well as body contact. In other words, if there's contact during the, for example, sexual act, for example, that's one other route. But it also could be routes through, for example, linen or bedclothes or clothes that are have been exposed to the virus, that it can and does survive, and therefore is a form of transmission. So in other words, fomite transmission. It's also important to note that when you have this particular infection, it's thought that you are not contagious only when new skin appears. So you do have this rash that appears, and the rash can last from 2 to 4 weeks. So during that period, even though the skin is speeding or debriding, it still is contagious. And it's thought that that level of transmission will only end once you have new skin. So that's a very difficult scenario to envisage in terms of managing cases. Therefore, isolation is really critical, limiting contact and hygiene, as well as certain particular sexual practices or during sexual contact to limit skin-to-skin contact. So that you can just imagine some of the difficulties that will be faced under those particular scenarios. Have I missed anything else?
I think you've covered it all, Prof. And I see Dr. Vea has joined us. We really seem to be having some issues due to load shedding in terms of connecting, but I'm glad she's able to join. Dr. Vea, do you have any additional comments based on the questions? I hope you got them over.
Thank you, Sine, and thank you, Prof. I think you answered the questions well. Maybe we'll hear from the panel if there's something that we can maybe expand on.
Okay, thank you so much, Dr. Vea. So if you can stay on the line, this time I have a question from you. Clip from Jacaranda FM, is it true that men who have sex with other men are at risk of being exposed to the monkeypox? And I think we have covered that this question, but I think it's very important that we establish understanding with everybody because there seems to be a misunderstanding somewhere. So Dr. Vea, if you can please come in to clarify the issue around what we're seeing epidemiologically in Europe and what the risk is to everybody. Over.
All right, so I'm gonna try and be systematic in my answer, and I hope that doesn't end up being a mess. So let me try. So first off, we believe that, or there's no evidence to suggest that there's different physical or biological susceptibility of or to the monkeypox virus. We are one species, our biology works the same way, and to the virus, it's the same thing. So there's no selection in terms of the group that's being infected from that perspective. So I think what's happening here speaks to maybe a bit of coincidence and incidental situation in this outbreak. Maybe early on during the outbreak, individuals that were or contracted the disease are men that are having sex with men in the context of their social structure, the people that they tend to be mingling with, people that they have very close contact with will also be men that are having sex with men. So we are seeing this outbreak in this way, perhaps because of behavioral factors. So certainly we see from the data from the rest of the world that almost 99% of the cases have been men having sex with men. I think that again also illustrates to us the very close contact, physical contact that is required for the transmission of the virus. So I hope that that, at least if you look at it that way, that allays fears in terms of, it doesn't spread the same way as COVID-19 or flu, and that is a good thing because that means it should be more easy to control. But it means that because of how things happened in this particular instance, and there are many other outbreaks where we also see viruses and other pathogens doing things in different ways because of the environment or the conditions of that particular event. And this is what we are dealing with currently. I think it's important that we do get to communicate that clearly and truthfully, and that we can, try and do away with stigma and negative connotations. We're communicating what is being seen in the field. We're trying to explain it but by looking at the data trying to make sense of that. And this is our current understanding of why we are seeing the outbreak perpetuating in this way. What one then needs to remember, because we are actually technically equally biologically susceptible to the virus, if the outbreak is not brought under control quickly, one could see more wider spread. So it's really important that we do see early containment of this outbreak and don't see perpetuated human-to-human transmission. I hope I hope that's given some food for thought. Thank you, Sine.
Thank you so much, Dr. Vea. We have gotten a lot of questions around this issue, and some questions were, is this a gay man's disease? And I think you've answered the question. The answer is no. Anyone who comes into contact, prolonged contact with a person who has the monkeypox virus is at risk of acquiring, regardless of their race, their gender, their sexual orientation, etc. And we hope that this information that has been provided will not be used maliciously. So Dr. Vea, I'm going to move on to, got quite a few questions from Tamar Khan from Business Day. She's asking if you can clarify whether the case identified yesterday was SA's first known case or the first one identified in the current global outbreak in SA. Can you also please provide an update on the situation provided this morning by the minister? Do you have any more suspected cases? What treatments are available, and does South Africa have a monkeypox vaccine? What is the protocol for close contacts? Do they all get tested? And are these tests available in private and public sector or only at NHLS? Over.
Thank you, Sine. You're going to have to help me get through the questions again. Just remind me. So the first question, just remind me quickly.
All right, so can you clarify whether the case identified yesterday was the index case or the first one identified in the current global outbreak in South Africa? That was the first question. Second question, can you provide an update on the situation?
I didn't sleep a lot last night. Can we do them one by one? I beg you.
I'll stop there. Please proceed.
Let me do that one quickly, and then let's go through the other one. Sorry to interrupt you, Sine. So we've never actually diagnosed a case of monkeypox in South Africa before. And actually before this May 2022 outbreak, that's the same for pretty much most of the world. So there's a handful of countries in Western and Central Africa where you can find the natural host of this virus. So this is a virus that is maintained in nature by an animal. And then there would be a spill over into a human population. It could be through a bite or some other contact that somebody had with the animal. And then there's the opportunity for human-to-human spread from there on. And that's what we're seeing currently. So in those countries where you find these animal hosts, over the many years that we've known monkeypox, and the first monkeypox case was diagnosed in the DRC in 1970, there's really only been few cases, especially if you compare it to some other infections that we deal with on a more regular basis. So handful of cases reported in those countries over the years. Then in 2003, there was an outbreak in the US where just around about 70 individuals were diagnosed. And in that instance, the outbreak was linked to the exotic pet trade. So animals from West Africa was exported as part of the pet industry in the US, and that set off a short-lived outbreak within the US. Then after that, the only other cases outside of Africa was noted from 2018 up until last year. So 2018, 2019, 2020, and 2021, there were actually multiple, but again, just a handful of exported cases of monkeypox, all of them actually from Nigeria, incidentally, to different parts of the world, Israel, Singapore, UK, USA. So that's the sum of it. Historically, a rare human infection. So again, what we're seeing now is something quite unique and a new, a new context in which we seeing monkeypox in humans. So no, we've never diagnosed a case in South Africa. That's true for most of the world before this current outbreak. And yes, the case that we identified yesterday was the first case that was confirmed. There's currently no other suspected cases. Of course, case tracing is underway, and it needless to say that we do expect that a few more cases will be detected, and we do hope that that remains at a low number. Next question, Sine.
I'm hoping you can talk on treatment. So there was a question from Khan and around monkeypox vaccine, and what is the protocol do they all get tested?
I could barely hear you, Sine. Is the question about vaccines?
Yes, it's a question around treatment and around monkeypox vaccines, and also the protocol for close contact. Do they all get tested? And are these tests available in the private sector as well as the NHLS?
Yes. So first off, the question about treatment. So this is a very mild infection. Look, I think it's probably very uncomfortable and I think disconcerting, of course, but it's not a fatal infection. Typically, cases resolve by themselves, so without any specific interventions. Doctors might try to treat the symptoms, so fever or pain or any discomfort that the patient might have, and they do that based on a case-by-case basis. There are some antiviral treatments that may be useful for monkeypox, but again, you know, this has been historically such a rare condition in humans that certainly it hasn't been a major, you know, one of the priorities, because, you know, when we look at the development of these treatments and development of vaccines, we want to do that for the diseases that we are more likely to encounter or are more severe. So up until now, there hasn't been a need for it. And then also added with the fact that these cases are very mild, typically no specific treatment, and in most cases, no hospitalization might be required either. So for the cases, so during case tracing, so the idea is to identify cases that could be at risk of contracting the infection and working to inform these individuals of their risks, and then working with them through what would be the incubation period of the infection. So depending on when the person was infected, there's a 3-week period through which they can be monitored to see if there's any signs or symptoms of monkeypox developing. Beyond that time period, the risk is then 0 unless the person is exposed again. So testing is really only useful once the symptoms of the disease is present, and the most sensitive way to test for monkeypox is to test the actual rash or the lesion material on the skin. So trying to do tests to determine if somebody was exposed to the virus is really not useful, and the test results would be misinterpreted and really just not very useful. So in terms of accessibility of testing, certainly we are working towards increasing accessibility for testing, but currently we are able to do testing. Also additional investigations like sequencing for any positive cases, which is really important for us to understand the bigger picture, the epidemiology of the outbreak. All of those tests and capacities are available at the NICD. And of course, as with many outbreaks that we've dealt with before, as the need arises, there is excellent laboratory infrastructure in South Africa. And I think that was demonstrated really well during COVID-19. The rate that we were testing at was really world-class. And certainly within that well-established laboratory framework in South Africa, there's capacity to expand testing if the need would be there to do so. Protocol for close contacts. There was a question. Is it a question about isolation, Sine? I
think you've answered it. It was a question around close contact, if they get testing and all that. So I think that's been covered. I'm going to move on to Kelly Jane Turner from IOLS News. So 2 questions from you, Jackie. If the first monkeypox case in South Africa was recorded in a person who has no travel history, does this mean there are possibly other cases in the country? Have there been any updates with regards to contact tracing again? So will SA be looking at how other countries have managed monkeypox outbreaks? If there's any increase in cases, what preventive measures could be put in place? Over.
All right. So yes, unfortunately, because there's no travel history for this particular case, so it means that the disease was acquired locally. So as I've mentioned already, the case tracing process is underway, and the idea is to identify the contacts that the individual had within the period of time that would make sense for, when we expect him to have contracted the disease, and then up until when he got sick, and then to trace back any cases. And then what we do with case tracing is pretty much trying to figure out and identify the chains of transmission. Now, with a disease that's transmitted in this way, and it moves fairly slowly within the population, again, it doesn't transmit the same way as COVID-19 or influenza. We are able, or we should be able to identify those contacts, work with those contacts, and then identify all possible chains of transmission. And then when you do have active cases, the recommendations are for those cases to isolate and thereby not transmitting the disease onto any additional individuals. So yes, it means that there are other cases in South Africa. How many? We can't answer at this stage, but investigations are ongoing. The second part of the question, remind me, Sinai, quickly.
Will SA be looking at how other countries have managed the outbreak? If there are increasing cases, what are the preventive measures that could be put in place?
I'm with you. Yes, so we always do that for everything. And public health is a very collaborative, globally collaborative field or science, if you will. And we learn from each other, and we always look to those with more experience and try to make then the best decisions in terms of managing health in our country as well. And that's true for public health, generally speaking. So, of course, we are looking at, amongst other things, also the World Health Organization recommendations, and they have released recommendations for pretty much all of the parts of the containment process that one would need to consider. So we've already adopted in South Africa case tracing and monitoring SOPs. There's an SOP for infection prevention control. But really the principle of the containment approach in this instance is what we call the classic containment approach. And that's exactly what we've been talking about this whole afternoon. It's identifying cases. So you're putting measures in place to increase your sensitivity for actually detecting cases. You are doing contact tracing and monitoring, and then isolating any confirmed, laboratory confirmed cases. And this is a tried and tested approach for infectious disease containment. This is exactly what was done, for example. I mean, it's not the same diseases, but I'm just going to give you the example of Ebola. If you remember the big West Africa Ebola outbreak from 2014 up until about 2016, massive multinational also outbreak across 3 countries where the epicenter of the outbreak was. And through, the vaccines for Ebola really only became available sort of towards the end of that outbreak, and it was used to a very limited extent. And it was through this approach that we've discussed now, and that an outbreak of that extent was actually brought under control. So this is a tried and tested way of approaching diseases like this. Now, the question about vaccination. So vaccination, of course, generally speaking, is a good idea or an amazing tool to have in your pocket to deal with these type of outbreaks, or to deal with, decrease the severity of diseases in general. And we know have talked about this quite a lot in terms of the COVID-19 vaccine experience. So yes, there are vaccines available. Some of these vaccines were actually not specifically designed for monkeypox. Some of these vaccines have been developed for smallpox, which was a virus which was eradicated through mass vaccination and is closely related to monkeypox. So smallpox vaccination actually also provides some level of immunity to monkeypox infection. And then in recent years, there has been vaccine candidates that have been developed specifically for monkeypox. And I believe one of those vaccines have been registered in some countries and by some authorities. So the general consensus at the moment and at the stage of the outbreak where we are now is that the cost benefit of vaccination is maybe skewed more towards not using mass vaccination at the moment. There are countries that are looking at very targeted post-exposure or pre-exposure vaccination in very targeted groups, but I'm not aware of any country currently that are implementing mass population-wide vaccination. Again, the cost benefit of this is not in favor of that at the moment. It will require substantial investment with, to contain in all likelihood very few cases. Of course, as with everything, one keeps looking at the situation, and if the need arises to do or to employ vaccination, then of course one needs to make those decisions and move in a direction. But certainly globally, currently, there's no recommendation or countries that are moving towards mass vaccination for monkeypox. Over to you.
I'm living my best Switzerland. Okay, thank you, Dr. Vea, and apologies for that distraction. I have some questions. I think they are for me, but I think I'm glad Prof. Piran is here. So Prof. Piran, I'm going to read these out for you. This is, hey, apologies if I am butchering your name. I'm open to learning how to pronounce it. Hayne from AfriNews. How will reporting on monkeypox work? Will there be a daily report like done for COVID-19? And also from Tamsin.
Sorry, so you're fading. Could you?
Okay, I'll go at it again. So how will reporting on monkeypox work? Will there be a daily report like COVID-19? And also Tamsin from Daily Maverick. How long before the physical symptoms of monkeypox does an infected person become contagious? Over.
Sorry, some of the questions were not clear. I think the first question was about the reporting. I think we will report based possibly on a weekly basis in terms of what we find. We're not expecting to see large numbers of cases, and this obviously depends initially at least. We're not expected to be overwhelmed as we were with regard to SARS-CoV-2. So I think the reporting will be somewhat different in terms of its frequency, but certainly it will be updated on a regular basis. And again, that will be either through the National Department of Health or the NICD.
Okay.
The next question.
The next question from Tamsin. How long before the physical symptoms of monkeypox does an infected person become contagious?
Yeah, so you can become contagious, I think it's about within 3 days of the start of the symptoms, right up to the point, as I said, when the actual skin actually heals. So the other point I want to make is that, again, many physicians are not familiar with this particular condition, especially in South Africa, so it'll be new, as it is for many other countries. The presentations can vary, so these may well be missed as well. So it is possible that even in South Africa, as I said, we've found this particular case, but it's likely, given that there's no travel history, that there may be other cases, and so these may well have been missed. However, it's really important to get a good clinical history as well as some travel history in order to make a clear diagnosis as well as a differential diagnosis to prevent further transmission of this particular virus.
Okay, thank you, Prof. I think we're at the end of our questions, so I'm just going to allow Dr. Vea to answer one last question very briefly. I'm hoping to wrap up by 4 o'clock. I know colleagues have other important engagements as well. So a question here from Bongani. Does that mean we might go back to lockdown? And I think that's our last question. So very briefly, Dr. Vea, and then I'd like to bring in Prof. Puren to wrap up on the key issues that we've touched on in terms of COVID-19 as well as monkeypox, and we should be done for the session. Over.
Thank you, Sine. I can't see any reasoning for bringing back any of the so-called lockdown measures to contain this particular outbreak. I think one can have a very long discussion about that, but of course, some of the reasoning of why we did undertake or had the lockdown measures that we had, and this was also seen in other countries around the world, was because we were dealing with a really great unknown, a completely new virus that we didn't deal with before, and we had or public health decisions had to be made to protect life to the greatest extent that was possible. I'll just leave that there. Having said that, again, with a virus that transmits the way that this one does, the way that monkeypox does, through very direct contact, and because it's clinically mild and won't overpower health systems, there wouldn't be any reason to employ some of the measures that we have seen before. We do take it seriously, though, and one wants to contain the outbreak globally as quickly as possible, because the more opportunity that we give the virus to continue to spread from humans to from person to person, unabated spread, may provide the virus actually with the opportunity to change. Now, monkeypox virus certainly doesn't mutate as easily as a virus such as SARS-CoV-2, for example. It's a DNA virus and not an RNA virus, so its evolution is much slower. But if we don't contain it, then we are affording the virus the opportunity to possibly change. So this is a really important reason why things need to be brought under control quite quickly. Otherwise, it's a disease that's clinically mild. It rarely causes death. There are risk groups, as with any other infection, but it's not likely at all to overpower health care systems in a similar way that COVID-19 has done. But we do want to contain the virus as soon as possible. And one can do that, and it will then be removed from circulation in the human population. Again, it's a virus that you can eliminate essentially in the human population largely. You will always have the risk of zoonotic transmission, again, in the countries where the natural host occurs. But person-to-person transmission can be largely eliminated. That's not so easy with a disease like COVID-19, for example. But no, that's the long answer to just a no. I can't see any reasoning for the lockdown measures that we've had for COVID-19 for the containment of monkeypox. Thank you.
Thank you so much, Dr. Vea. Prof. Puren, if you can make closing remarks, and then we can close up. Thank you.
Thanks, Cynthia, and thanks, colleagues, for being on this call. I hope that was helpful for you. So there you have the story of two very distinct outbreaks, and outbreaks that are also affecting South Africa quite clearly. The one, I think, in terms of COVID-19, we've reached this particular point, and have we reached this point of transition, where we have certainly lifted up many of the restrictions. However, I think there still needs to be caution practiced, especially those who are vulnerable in our communities. And therefore, I think even though these restrictions have been lifted up, I think it's still clear that we need to do various risks assessments, either as employers, employees, and as individuals, as to how we will behave with regard to the wearing of masks, for example, and the reduction of physical spaces. So the vaccine program is really critical to COVID-19, and we really would like to encourage people to be vaccinated, to be fully vaccinated, and to take advantage of the boosters. I'm sure there will be a time when there will be a universal vaccine were we to reach that particular point. With regard to the pox virus, a very different virus, behaving very differently with specific characteristics. I think the WHO is meeting today whether to declare whether this is a public health emergency, given the nature and the extent of this particular virus in terms of its current spread. As Jacqueline has quite rightly pointed out, it's really critical that we do control this particular virus. It does require intensive contact and tracing in South Africa as well to ensure that we identify the cases in order to really limit transmission and to limit morbidity. Thus far, this virus is not proven to be fatal, even though there is a case fatality rate that has been published. But so far, as far as I'm aware, there's probably only one death that relates to this current outbreak. Nevertheless, it's really important that we get this under control as soon as possible, using both public and private sectors in terms of case identification and testing and tracing. I think that that's really going to be critical. So it's a different virus, different behavior. It's very important that we get it under control. So thank you very much, everyone. I hope that we've answered your questions satisfactorily. There are opportunities again to send questions through, and we will try and respond to them as soon as possible. So thank you so much, Lata. Thanks very much.
Thank you so much, everybody, for joining us, and thank you, Dr. Vea and Prof. Puren. We do apologize for the sound today. It was beyond our control with the switch on, switch off in terms of electricity. Thank you so much, and we hope to see you again in our next session. And if you do want to reach out, my email address is sinenhlanhla@nicd.ac.za, and we'll be happy to assist you. Have a good afternoon further. Thank you.